Good morning, everyone. It is such an honor and a pleasure to be able to do the introduction for the 2024 Sheila Cohen What's New in Obstetric Anesthesia lecture. This was a lecture that was started in 2012 to honor the legacy and the career of Sheila Cohen. She worked here for 39 years. When she showed up in 1973, there was no obstetric anesthesia division. In fact, there was only 2 faculty that actually wanted to do obstetric anesthesia. Everyone else was dragged there. She created the entire division for which we benefit still to this day. And she totally changed practice both at Stanford and nationally. At Stanford, she came in and did a lot of things that were for us now just, we expect this is how care is, but it wasn't at that point in time. Women were tied down during C-sections, so the first thing she did was take down those straps. She gave women a lot of autonomy in a lot of clinical practice that they changed. So for example, there are things like we use neuraxial opioids without thinking about it. These were changes that were made by Sheila, both locally and nationally and internationally. And she entirely defined contemporary obstetric anesthesia practice over the years with a few others. So these are the benefits we see every single day, and women benefit from it every day as they walk around with their mobile epidurals and various other benefits that we've had. But probably the biggest impact for especially the obstetric anesthesia division was on a personal level. So she's the reason I came to Stanford, and she was my mentor both from a work point of view as well as a life point of view. So she takes full responsibility for my life. But a lot of others in the division feel the same way. I mean, she's really made a very big impact, a very powerful female leader who's been a mentor to many people. So Sheila Cohen, I hope you enjoy this lecture. And if you want to stand up, some people have never met you, they can at least get to see you.
Mentoring Brendan is a full-time. Now he's how many people?
Yeah, I do.
17.
All right, and then what makes this particular lecture special is we have our very own Pervez Sultan who's giving it. So I'm going to be able to call him in 3 weeks Professor Pervez Sultan. He's getting promoted in April. So Pervez came here in 2010 to do a fellowship, and then I spent the next 8 or 9 years begging him to, firstly not leave in the first place, but then return. And he finally in 2019 returned. So he's been here just less than 5 years, and in that 5 years has been quite phenomenal. He's published over 70 publications in that time period. And while he came here, not only was he doing that, he was actually got his first R01. Now, to get an R01 is difficult, but to come in without that sort of feeder from farm to fair to K, where you're being mentored into this and coming out without any funding experience in the US is quite phenomenal. He's been on a lot of other research projects, extremely collaborative in these U54 and a lot of the MCHRI grants. So what has he done with this research? He's essentially redefined the field of recovery following childbirth. So he's developed a patient-reported outcome measurement tool, the OBS-QR10, which is essentially an adaptation from the quality of recovery 40 tool that's used in surgery that is now translated in, I think, 13 languages around the world. It's quite amazing. And then he's now moved beyond the period of the hospital into the postpartum period, defining a new patient-reported outcome measure, the STORK, that measures global recovery after childbirth, and then is looking at specific domains. So his R01 is specifically looking at sleep. And he promises me he's not going to demonstrate the sleep domain during his lecture today. On a personal level, he's just an amazing human being, clearly the triple threat of clinical excellence, education, and research. He's smart, clearly, but his work ethics is fairly impressive. And, if you want to be successful in research, you have the work ethics like Pervez. It's quite amazing. He's always got a smile on his face. He's always collaborating, networking. You have no idea how many connections he has around the world doing research projects. It's quite phenomenal. So it's a great pleasure to introduce him for this lecture. Now, this is a very special lecture. They give it to a leading person in the field of obstetric anesthesia Every year, someone's named to do this. So it's a very big honor getting this. Actually, Brian had this honor a few years ago as well. What it does is it summarizes all the research over the past year. So for this, it's actually 2022. It's an incredibly difficult task to do because you've got to read something like 40 journals and summarize it all within one lecture and produce a big document. So anyone who takes this on is kind of crazy. And not only did he take it on, but he took it to the next level. No one wants to actually do this lecture anymore. He created, we'll see the infographics of this, and thanks to Larry Chu, an app that came with it. I mean, you name it. I mean, it was pretty impressive. Arguably the best ever Ostheimer lecture. In fact, Brian would agree, even though he's given it. I mean, it was fairly amazing. So anyway, without taking much more of his time, Pervez, Sultan.
Brendan, thank you for those lovely words. And Sheila, working with you was one of the highlights of my career, so I hope I do this talk justice. Okay, so we've got lots to get through, but I don't have any relevant financial disclosures. There's 2 publications which have just been accepted for publication. One's in the International Journal of Obstetric Anesthesia, and the other is in Anesthesia and Analgesia. So watch this space, but you're getting a sneak peek with today's lecture. So in 2022, which is the year of literature that I reviewed for this lecture, there were 1.8 million publications on PubMed alone. And I've had the unenviable task of distilling 12 months of important obstetric anesthesia literature into this 50-minute talk. So I apologize if I miss any important articles. And if there isn't anything in this lecture today that you think that should be, the chances are that it made it into the lecture syllabus, which is available through the QR code on every single slide. So the mainstay of article selection for this lecture was made through developing a standardized search criteria with the help of a medical librarian based at University of Arkansas for Medical Sciences. I hand searched 66 different journals based on their previous use in Ostheimer lectures and their impact factor. For the first time, I actually supplemented this with a Twitter search looking for hashtag OB-anesthesia or OB-anes. And I also supplemented this search with scouring the internet for professional society guidelines, recommendations, and statements. In total, I reviewed over 4,000 titles and abstracts, and in the syllabus, there are 108 articles, and in the lecture today, I'm going to try and cover 32. These articles were selected based on their novelty and their potential for clinical and research impact. So if you take a moment to visit ostheimer.app or just access it through the QR code, you'll first be presented by my ugly mug. And then if you scroll down the bottom, you can learn about the original lecture, and then you'll actually have access to all of the articles that I'm going to talk about today. You can click on any of them, and then you can select your favorites based on your clinical and research interests. And there's actually a full PDF link for all of these articles as well. And I've also provided the slides as well, which you can download as a JPEG. And once you've downloaded it onto your smart device, then there is an opportunity to tweet as well through the app. And there's a pre-populated tweet that you can edit as you see fit. But remember just to add the JPEG that you've saved to your smart device. In addition to this, along the bottom, you'll see a link to the syllabus where you'll be able to see the 66 articles that I screened and the full search criteria. And then I've also included titles and abstracts for all 108 papers. And also along the bottom, you'll be able to watch a live replay of the original Ostheimer lecture that I gave in the SOAP meeting. Okay, so the intended uses for this app are hopefully to help guide clinical care, to be used as a teaching aid, and to guide research focus over the next year or two. I've divided this lecture into 5 different sections. And first of all, we're going to talk about some issues pertinent to global maternal healthcare. And then I'm going to focus in on some studies relevant to North American practice. I'm then going to follow a patient's journey from the antenatal period to studies relevant to analgesia and anesthesia. And then I'm going to talk about a couple of studies that are close to my heart in terms of postpartum recovery, which is my particular area of research interest. So let's kick off with global maternal health care. A fun fact is that over the next 4 minutes, there will be 1,000 babies born around the world. And the majority of these births will actually be happening in Asia and Africa. And this is hugely important because the latest World Health Organization data states that there is one maternal death that happens every 2 minutes around the world. And the vast majority of these deaths are happening in low and middle income countries, which are least well resourced when it comes to anesthesia. Most of the deaths have been identified as being preventable, and therefore there is lots of work to be done in the peripartum space. The cesarean delivery rates globally are around 20% at the moment and are estimated to increase to around 30% in the next 6 years. So there is lots of work for team anesthesia to do. Anything that we can do to improve peripartum outcomes is likely to impact a very large number of patients around the world. So let's look at some of the challenges that low and middle income countries are facing. This is a study that was seeking to identify some of the challenges in implementing the 2012 World Health Organization postpartum hemorrhage guidelines. Now, we know that PPH is one of the leading causes of maternal mortality around the world. So this group performed a retrospective review of maternal PPH-related deaths by using the Kenyan Confidential Inquiry into Maternal Deaths database over a 3-year period. Over this time period, there were 725 mothers that died from postpartum hemorrhage, and rather shockingly, only 4 out of 10 of these patients that died received prophylactic uterotonics, which is shocking considering the widespread availability of drugs such as these in Western settings like our own. Some of the bottlenecks that were identified in this important study was the lack of drug availability of life-saving drugs such as misoprostol, tranexamic acid, and heat-stable drugs such as carbetocin. There was also a lack of skilled personnel to administer these drugs and a lack of training surrounding when best to administer them. And in addition to this, there was inconsistent drug quality, so there was problems with drug manufacturing standards, transportation regulations, and also adequate storage and refrigeration of these important drugs. So these are public health priorities which need to be urgently addressed through legislation. Next, I want to talk about a success story in terms of maternal mortality, and that is what's been happening in India over the past few decades. So the United Nations Sustainable Development Goal targets have stipulated that by 2030, no country in the world should have a maternal mortality rate of greater than 70 per 100,000 live births. So this was a national cross-sectional study across India using a variety of different sample sources and sources for data, including WHO and UN maternal mortality rate data. They included all deaths this time, and this was over a 23-year period. And over this time, you can see that it has been a success. There's been a significant reduction in maternal mortality rate from around 400 to 100 over this time period, but there's still lots of work to do. In 2020, around 60% of the deaths were in mothers that were aged between 20 to 29 years old. That's around 24,000 deaths that happened in India alone. The causes of death mimic what's happening in other countries around the world in terms of hemorrhage, infection, and hypertension being leading causes of maternal mortality. One thing that was really important from this study is that it quite nicely highlighted the geographical disparities, which are demonstrable in every single country. In this particular country, the states in the north and northeast have significantly higher maternal mortality rates compared to states in the south. So in this case, Assam has a maternal mortality rate more than 4 or 5 times compared to Kerala. And actually, Kerala has a maternal mortality rate lower than some of the United States, states such as Texas. So this is an important study because it highlights the need for targeted national and international efforts to reduce maternal mortality in order to achieve the UN SDG targets. Next, let's move to lessons we can learn from the Western world. And this is a summary of data from the 9th triennial report from the United Kingdom, looking at maternal deaths up to 1 year postpartum. Each of these deaths was analysed by a group of 15 experts, and the standards of care were compared to known professional society guidelines and standards. In total, there were 536 maternal deaths which were reviewed over this 3-year period. And one of the take-home messages was that 11% of the mothers that died in this cohort had evidence of disadvantage as defined by these 4 bullet points. In addition to this, similar to India, there were geographical disparities once again, with patients from more deprived areas around 2.5 times more likely to die compared to patients from less deprived areas. And also this study highlights quite nicely the importance of the 4th trimester of pregnancy, with the postpartum period being responsible for 86% of the maternal deaths. And the majority of these deaths are actually happening after week 6, which in the United States is when most people stop being followed up and when insurance stops to be applicable to patients as well. So this highlights an area where we can actually modify the current healthcare service that we provide. In addition to the geographical disparities, there were also racial disparities highlighted once again. This is not new data, but we know that Black mothers are more likely to die compared to white mothers from all causes and suicide as well. So what can we learn from this? We need to screen patients in the peripartum period for disadvantage and take it seriously and feed them into psychiatric services at an early stage. And in addition to this, we really need public health efforts to address the known disparities geographically, socioeconomically, and in terms of race and ethnicity as well. Next, I want to talk about a really important report from the United Kingdom. This was actually the largest government-sanctioned external inquiry into a single hospital that failed its patients. This was an independent review in a single hospital in the Midlands in the United Kingdom, and over a 50-year period, there were around 1,600 critical incidents that were reviewed in this report, which resulted in the avoidable deaths of 12 mothers, and 1/3 of the stillbirths that happened over this time period were deemed to be avoidable as well. So some of the lessons that we can learn from this 235-page document are the fact that it's important that we don't chase targets. So at the time, in the National Health Service in the United Kingdom, cesarean delivery rate was a quality metric. And this hospital actually had C-section rates 10% below the national average. And this culminated in a culture of avoiding cesarean delivery, which resulted in avoidable maternal and neonatal deaths. In addition to this, there were repeated cries from people working on the shop floor to the C-suite that they were inadequately staffed and inadequately trained to deal with the levels of complexity of patients that were coming through the door. But there was a disconnect between the leadership and people that were working on the shop floor. So this highlights the importance of adequate staffing, and also QI, to learn from one's mistakes, is hugely important. And I think this is something we do very well here at Stanford. Okay, so moving on to some of the studies relevant to North American practice. So similar to the Embrace report from the United Kingdom, we have CDC data now, which summarizes maternal mortality up to 1 year postpartum from Maternal Mortality Review Committee data across 36 different states. Over this 3-year period, there are around 1,000 maternal deaths that were reviewed by an expert committee. And once again, the postpartum period was highlighted as a hugely important time, which is when the majority of maternal deaths are happening in the United States. And for the first time, psychiatric disease was identified as the leading cause of maternal mortality, accounting for 1/3 of the maternal deaths. And similar to the WHO data and from data from the lower middle income countries, the majority of deaths in the United States are considered to be preventable. So this highlights the importance of screening for psychiatric disease and for addressing the deaths that are happening in the postpartum period. Next, I want to talk about adverse events specifically related to obstetric anesthesia. This is a study from Canada that sought to identify the frequency and risk factors associated with adverse events in the obstetric anesthesia setting. They used a very large retrospective data set from the Canadian hospitalization database. Patients were included if they were above 20 weeks gestational age. So there was about 2.6 million anesthetics that were considered in this very large cohort over a 13-year period. They defined adverse events as described on this slide, with italicized items representing severe adverse events. So the rates of or frequencies of adverse events in obstetric anesthesia were pretty rare, but there were about 10% of these were classified as severe. Not surprisingly, the majority of these adverse events are related to spinal and epidural headaches. The rates of failed and difficult intubation were reassuringly low, but more common in patients that have a neuraxial anesthetic followed by a general anesthetic. And you can imagine these are patients that either have an emergent surgery or have intraoperative breakthrough pain or hemodynamic instability for some reason. The rates of adverse events were slightly higher in patients that had a cesarean delivery compared to normal vaginal delivery. But once again, it was more common in patients that had general anesthetic compared to neuraxial anesthetic, and 7 times more common in patients that had a neuraxial and a general anesthetic. There was a nice accompanying editorial by Lee and George, which highlighted the importance of us as obstetric anesthesiologists to be able to act up as perioperative physicians and deal with not just these complications, but other emergencies as they crop up as well. And it also highlighted the importance of developing quality metrics that are specific for obstetric anesthesia. So with this in mind, the ASA subcommittee in obstetric anesthesia developed this list of quality metrics, and I was very fortunate to be part of this committee. But we divided the recommended quality metrics into cesarean delivery and labor metrics. And some of the C-section ones are GA rates, supplemental analgesia rates. There's some metrics surrounding prevention and treatment of spinal hypotension and proportion of patients and education surrounding opioid use in the hospital and in the postpartum period. And there are some labor metrics surrounding timing and delays of neuraxial anesthesia and analgesia, and surrounding post-dural puncture headache and treatment with epidural blood patch. So these are things that labor and delivery units should be collecting routinely up and down the country and presenting the data to each other on a quarterly basis like we do here at Stanford. And we can learn from our mistakes, and we can congratulate ourselves when we are performing well, but also recognize areas that need improvement, and we can benchmark our practice and compare to other institutions as well and learn from each other, most importantly. And also these are some metrics that we can learn about how to research best and how we can improve these rates. Next, I'm going to talk about a bit of an elephant in the room in the United States, and that's a metric surrounding safe staffing on labor and delivery. We know from the SOAP Center of Excellence, which Brendan Carvalho actually set up, that we can aspire to have an anesthesiologist attending on labor and delivery 24 hours a day, 7 days a week. That's what we ideally need, and you need that to be a SOAP Center of Excellence, which Stanford is. However, we don't know what the minimum staffing levels should be. There's some hospitals in the United States where an anesthesiologist will place the labor epidural and then go home and be on call from home after that. So there's clearly a huge disconnect between what's happening in academic centres versus rural centres. In the United Kingdom, there are recommendations surrounding safe staffing models. However, these cannot be directly applied to our setting due to differences in trainees alone running the service out of hours. So Mary Im, who was our previous OB anesthesia fellow, actually surveyed the SOAP Centers of Excellence within the United States and then developed the Stanford Work Index. A work index of 1 represents that the anesthesiology attending is either in the OR or performing a neuraxial procedure for the entirety of their shift. So from this data, we can see that the average workload is around 1/3 of the attending anesthesiologist's time is spent in the OR or performing neuraxial analgesia in the labor and delivery room. And there was no significant differences between academic and non-academic centers, but weekday work tends to be a little bit busier than night and weekend work, which was not really surprising. What this doesn't take into account, which was highlighted in an accompanying editorial, is that it doesn't take into account all the other things that we do in labour and delivery. So stabilisation of sick patients, transfers, lines, pre-evals, consults, all that kind of stuff. So we can't use this directly, but it's a good starting point to get an idea of how to go about making staffing levels. But also, I think it's important to appreciate that it's not just the average workload that should determine minimum staffing levels, but our ability to flex up and deal with the busiest periods, and also to deliver that excellent quality of standard of care using the ASA metrics on the previous slide. So there's still lots of work to be done in this area, and we are trying to tackle it in the ASA at the moment. Next, I want to talk about something which shook the world in 2022 and continues to do so in many mothers' lives in the United States, and that's the changes to abortion protection. This culminated in many high-impact editorials, but it hit the mainstream media big time. So the Society of Obstetric, Anesthesia and Perinatology released this impactful statement stating that SOAP believes that people should make their own medical decisions in conjunction with their healthcare providers without limitations or bias posed by institutional, legislative or other policies. But as it currently stands, most US states do not currently protect abortion. There was a really nice editorial by Cynthia Wong and colleagues published in the British Journal of Anesthesia, which quite rightly points out that previous lessons that we've learned from other countries have identified that banning abortion does not affect the number of procedures performed, but it certainly does impact safety. From Mexico, data has previously shown that decriminalizing abortion actually reduces rates of severe maternal morbidity. So it's been hypothesized that these changes in abortion laws within the United States is likely to impact underrepresented minority groups such as Black women and Hispanic women the most. And we know that these are already at-risk groups from historical data within the United States. And unsafe abortion is the leading cause of maternal mortality around the world, according to the WHO. Let's think for a moment about the potential impact on ourselves and our colleagues in certain states within the United States. These changes in law are likely to increase provider hesitancy, particularly when caring for patients that present with ectopic pregnancy and premature rupture of membranes. And it's already having an effect on where people are choosing to do their obstetric residencies, as demonstrated by a JAMA article published last year. But not only that, there will be a generation of obstetric anesthesiologists and obstetricians that have never performed these procedures. So if there is ever a change in the abortion law, there may actually be an uptick in maternal mortality and morbidity related to safe provision of these operations. So there's lots of things to think about. But as it currently stands, each state is a laboratory for experimentation surrounding this, and there are studies starting to come out looking specifically at morbidity and mortality related to these changes in abortion law. Okay, so let's start thinking about a patient's journey from the antenatal period up to postpartum. And this is a really great study by our own chair, Brian Bateman. And this was published in the New England Journal of Medicine. So it's not every day we get to do that as obstetric anesthesiologists. So congratulations to Brian for this. But this study aimed to address the fact that there's 1 in 10 pregnant patients in the United States that suffer from substance misuse disorder. And often these patients are treated with either buprenorphine or methadone. So this study sought to see whether one was better than the other in terms of maternal and neonatal outcomes. So this was a massive retrospective cohort study using Medicaid data, and the patients were divided into different cohorts according to their gestational age. There was 18 years worth of data. For each of the different sub-cohorts, there were more patients treated with buprenorphine compared to methadone. But you can see from these emboldened items, the first 4 items, that methadone was associated with less favorable outcomes compared to buprenorphine in terms of neonatal outcomes, but there were no differences in maternal outcomes. And actually, Brian's just published a paper in JAMA Internal Medicine, also adding to this, stating that buprenorphine is more favorable compared to methadone in terms of congenital birth defects as well. So congrats again on that paper. Next, I want to talk about penicillin allergy, and this is a bugbear that many people have. 1 in 10 of the patients that we see on labor and delivery actually claim to have a penicillin allergy, but only 1 in 10 of those patients have a true allergy. And the American College of Obstetricians and Gynecologists in 2020 recommended that patients that are pregnant can safely have penicillin allergy testing, but this isn't routinely done in the vast majority of places. This is important because 1 in 3 pregnant patients develop group B strep, which can be optimally treated with penicillin. So this can actually influence the care of a lot of patients. So this was a really nice demonstration of how we can publish QI in a high impact journal. So a great quality improvement project from the Mayo Clinic, single center, that introduced this nursing-led algorithm of identifying, referring, and testing pregnant patients for penicillin allergy. So over this time period, there were around 236 patients that reported an allergy, but about 85 of these patients either presented in labor or had such a strong history of anaphylaxis it wasn't worth testing. But the testing was offered to 150 patients, of which a third declined, but there were 100 patients that were tested. 94% of these patients, as expected, were not allergic to penicillin. And of these patients, 17 went on to develop group B strep and were successfully treated with penicillin. So I think this is a really nice demonstration of how penicillin allergy testing can be implemented. It's safe, it's feasible, and it can directly impact clinical care. So this is something that maybe we can own in the perioperative physician space. Next, I want to talk about some studies related to analgesia and anesthesia. And the first is regarding a common day case procedure which is performed up and down the country, and that's cervical cerclage. Most places do a spinal anesthetic for this, and most places administer bupivacaine. But with the demands that we have on labor and delivery floor space, this study sought to see whether the recovery was quicker and ability to discharge readiness was quicker in this patient population if you use 3% chloroprocaine intrathecally compared to bupivacaine. So this was a study performed at Columbia University, a double-blind randomized controlled trial where patients were randomized to either have chloroprocaine spinal versus a bupivacaine spinal. Both groups got 15 micrograms of fentanyl. And the primary outcome measure of time to resolution of motor block was not different between the groups. But you can see here from the emboldened items that sensory block resolution and discharge readiness time were 60 and 70 minutes reduced in the chloroprocaine group compared to bupivacaine. And there was no difference in intraoperative anesthesia, so rates of having to convert to general anesthetic, for example, and rates of side effects as well. So there was an effective dose finding study also from University of Arkansas for Medical Sciences and Duke University, which advised the use or elucidated that the ED90 effective dose in 90% of the population was around 50 milligrams, which is similar to what was used in the Columbia study. Discharge readiness time was similar to the Columbia study as well, but take a moment to see the surgery duration. So it was about 35 minutes in the Columbia study and around 15 minutes in this study. So we're a little bit longer in terms of surgical duration here at Stanford, so we haven't implemented that here. So before we change over to chloroprocaine, there's a few things we have to think about. So if you did think about introducing this in surgeries that were likely to be a bit longer, you may need to do a CSE to supplement your anesthesia. But also 3% chloroprocaine is not FDA approved. There is a 1% preparation which is, but that has been inadequately studied in the obstetric population. So a few questions and discussions that need to happen at a group level before instituting this routinely. Next, I want to talk about labor analgesia epidural solution concentrations. We published a meta-analysis quite a few years ago, it was about 10 years ago now, demonstrating that if you use concentrations of bupivacaine more than 0.1%, then this will actually increase your risk of an instrumental delivery. It increases urinary retention and also increases motor blockade as well. So we know that concentrations at less than 0.1% are good. But we don't know whether there's any additional benefit in reducing the concentrations further. So this was a really nice network meta-analysis which looked at high, low, and ultra-low concentrations in these 32 different randomized controlled trials with almost 3,700 patients. The knowledge gap is there a difference between low and ultra-low? And you can see from this table that this was a negative study. And what we can take home from this is that as long as you're using concentrations of 0.1% bupivacaine or lower, then you're probably in a good place. Next, I want to talk about a study which was actually published last year from University of Arkansas for Medical Sciences. So this is a nice study demonstrating the potential benefits of DPE. So a dural puncture epidural is basically a CSE without administration of intrathecal drugs. And this group hypothesized that by doing a DPE, you actually could speed up the rate of conversion to anesthesia when you do an epidural top-up, because the hole in the dura will actually encourage the translocation of drugs from the epidural to the intrathecal space. And so they used a really novel model where 2 hours before an elective C-section, patients were invited to come into the hospital and have either a DPE or a standard epidural placed, followed by labor analgesia solution infused, just like people do when they're laboring. And then when the surgeon and the OR were ready, the labor analgesia solution was stopped, and then a stat dose of 20 cc's of 3% chloroprocaine was administered to mimic what happens in a stat C-section scenario. The primary outcome measure for this study was time to achieve a T6 block. And you can see from this Kaplan-Meier plot that there was a significantly quicker onset associated with a DPE, 4 minutes quicker. So I think this is a clinically significant difference. In addition to this, there was a composite outcome measure of quality of anesthesia. So this is requirements for replacing the catheter, for performing GA, requirement for supplemental anesthesia. And this was also significantly better in the DPE group. One word of caution here is that the fact that there was less than 2 hours between siting the DPE or epidural and performing the C-section. So we don't know whether these effects persist beyond this, but this is something that maybe we should look at using our DSI database. Next, I want to talk about use of uterotonics in the C-section setting. So postpartum hemorrhage is a leading cause of maternal mortality. And even though there's international consensus surrounding optimum administration of uterotonics, the vast majority of institutions around the world still give a 5-unit bolus of oxytocin followed by an infusion, or in countries that have carbetocin, they give 100 micrograms of carbetocin. So this was a study that sought to perform a non-inferiority analysis comparing low doses to high doses of oxytocin and carbetocin. And this was once again a negative study in patients that were at low risk of postpartum hemorrhage. So the conclusion here is that if you have someone who's at low risk of postpartum hemorrhage, who's having a spinal anesthetic, then maybe consider using the lower dose of oxytocin compared to the higher dose. And we do use lower doses here at Stanford. Next, I want to talk about something that's gained a lot of social media interest in the past couple of years, and this is the prevalence of pain and inadequate anesthesia during cesarean delivery. So we know that the gold standard mode of anesthesia for cesarean delivery is either is a regional anesthetic technique, but what we don't know really is the prevalence of intraoperative breakthrough pain, and indeed what the impact of this can potentially be on mothers in terms of psychological sequelae. So this was a systematic review of randomized controlled trials in patients that were undergoing scheduled C-section with adequate doses of local anesthetic. So this was a high quality data set summarizing 54 randomized controlled trials. So there was a low risk of bias in this data set. The take home message is that for patients having an elective C-section, the prevalence of either needing a GA or some kind of supplemental analgesia is around 15%. So when this first came out, Brendan didn't believe it. But then, so some people think that this is an overestimate, whereas actually there was an editorial that accompanied this paper by a patient who's previously experienced pain, claiming that this was an underestimate as well. So in response to this, we're actually leading a multi-center study. So we're now recruiting 20 patients from 28 different centers. This is a SOAP research network study, which I'm glad to say that we're the lead site on. So hopefully we'll get prospective data to answer this question definitively. And we're also performing qualitative interviews with patients who experienced pain to identify how severe and the potential impact on these patients as well. So lots of work currently being done in this space. In the meantime, how can we manage intraoperative breakthrough pain? This is a summary of an expert consensus surrounding optimal management from the UK, and they've divided their recommendations into 5 different sections. So first of all, acknowledge the patient's in pain, stop the surgery if possible. It may not be possible if there's immediate threat to the mother or baby's life, or if uterine incision has already happened. But whatever happens, I think it's really important to engage with the patient and discuss the possibility of general anesthesia. If there's an epidural in situ, then obviously you can potentially use this to provide extra analgesia. But we've got lots of other things such as nitrous oxide, IV opioid, IV ketamine. And this is a UK consensus, so there was no mention of dexmedetomidine or chloroprocaine splash, but those are other things in our armory as well. The important thing is